right, welcome everybody. Thank you for coming. We have some people on Zoom as well. We need to make sure we have everybody. We do. Okay. All right. One of our mental health ambassadors is going to kick us off with introductions and then pass it over to our speakers.
I don't want to take up too much time with introductions. Also, if I talk weird, it's because I've never used one of these before. It's really exciting. My name is Prakruti. I'm a first year OMS medical student here, and also a mental health ambassador, which is really cool. Thank you for handling the computer, Sarah. I don't know what to do with it. I'm not going to take up too much time. I have some like prepared introductions. I'm just going to walk you through them. If you have questions, please save them till the end. We will have time for questions afterwards as well. Um, Good evening, everyone. Thank you for being here, whether you're joining us in person or tuning in via Zoom for tonight's special event in honor of Show Me Compassionate Medical Education Day. This day is a reminder of the importance of compassion, not just in the way we care for our patients, but also in how we care for each other and ourselves, especially in the world of medical education and clinical training. Tonight's event, Osteopathic Views of Mental Health, Then and Now, is a reflection of that commitment. We'll be exploring how osteopathic philosophy has shaped and continues to shape our understanding of mental health, whole person care, and wellness. I especially want to recognize our mental health ambassadors who are here with us tonight. Your presence speaks volumes. You are leaders in promoting a culture that prioritizes mental health and well-being. And events like this wouldn't be the same without your thoughtful participation and support. We're incredibly fortunate to be joined by two remarkable speakers who bring a unique blend of historical insight and modern clinical expertise. First, we have Dr. Jonathan Terry, a proud Truman State and KCOM alum and a true Kirksville enthusiast, though now he resides in Central California for, as he says, better beach access, which is awesome. Dr. Terry is board certified in both psychiatry and integrative medicine and is a National Health Service Corps Scholar. His clinical work focuses on underserved and vulnerable populations, including migrant workers and high acuity psychiatric patients. He serves as assistant dean at California's newest DO school and also provides expert witness consultation in state and federal court systems. Beyond the clinic and courtroom, Dr. Terry has published in both literary and professional journals, but he's especially proud of his educational coloring books, which help fund charitable care and free clinics. That's really cool. Joining him is Mr. Jason Haxton, director of the Museum of Osteopathic Medicine. He's here in person, right here at AT University since 2001. Jason has brought osteopathic history to life, not just in Kirksville, but around the globe. He lectures internationally, contributes to medical curriculums, and he's helped develop award-winning documentaries such as PBS's The Feminine Touch. He's also authored the first youth biography of Dr. A.T. Still, which is now part of school social studies curriculums. Under his leadership, the museum has received over $500,000 in grants and was most recently awarded a national IMLS grant to expand artifact preservation. Jason's efforts have made the museum an internationally recognized shining star of the osteopathic profession. Together, Dr. Terry and Mr. Haxton will guide us through the evolution of mental health within the osteopathic tradition, from its foundational philosophy to the future of compassionate care in medical education and practice. Please join me in welcoming our speakers, and thank you all again for being part of this important conversation.
All right. Thank you for the wonderful introduction. Can the folks on site hear me? I think I see Dr. Thomas coming up to say, yes, we can. All right. We'll go ahead and get started. And again, I do want to thank AT Still for hosting. The last time that or I should say the first time I had a chance to present with Mr. Haxton in the Mohegan classroom was 19 years ago. So I'm really delighted to share this opportunity. Tonight's presentation we appreciate it's a busy school night in some ways. There's a lot going on for many of our attendees. So we're going to start with a very contemporary view of mental health and psychiatry, talk about where we're at now. Then Mr. Haxton is going to be taking us into the past a bit before we regroup here in the present. So many of us are familiar that mental health in the United States leaves a lot to be desired. Mental illness is incredibly common. It's something that affects 1 in 5 adults, or about 50.3 million people at one time in 2022. A little bit more commonly diagnosed in women, and young adults are particularly susceptible, with a little bit more than a third of young adults at some point receiving a mental health diagnosis. In spite of these high numbers, the mental health infrastructure is arguably quite lacking. And we'll see how that compares to A.T. Still's time. Currently, we know that there has been a decrease in psychiatric beds, and I can tell you for any students who are applying for psychiatry or going into it, it's a competitive field with not enough spots relative to the need for how many we have. The mental health workforce includes people like myself who are psychiatrists as well as psychologists. And then we also have master's level counselors, marriage and family therapists, clinical social workers, large numbers of people trying to meet this need in the United States. We can say that in Kirksville, for example, or wherever folks might be, if you or a family member needed a referral to see somebody in mental health, if I was there in person, I might ask you a question of where in the United States is the only place you're guaranteed access to mental health services, and it's actually in correctional settings. So I'm not necessarily recommending anybody take a stay in jail or prison, but it is one of the few places that we have guaranteed access to mental health. One of the things that's concerning is that many people who need mental health treatment or who would benefit from it, they have payment issues or other problems. And medications and therapy, which are kind of the standard of care aspects that if I were say an allopathic psychiatrist, I might say these are some of the tools, the more common tools I have available to me. Those are very widely utilized and perhaps both under and overutilized for reasons that we might not get to entirely in this conversation. But I do think it's important, giving this presentation from all the way on the West Coast to our friends there in Kirksville. In Missouri, not surprisingly, the Still family had some very unique ideas and approaches to mental health that were revolutionary then and arguably are still quite progressive for how we might consider things now. With that, I'm going to go ahead and pass the figurative microphone to my friend, Mr. Haxton, to take us back in time a little bit and tell us how we got where we are.
Thanks, Jonathan. As we look at this picture, I wonder if this arrow, oh good, moving that arrow out of the way. It's driving me crazy. Very early on, when Dr. Still first came up with the idea of manual medicine, every case was kind of unique to him. And as he was traveling in south of Kansas City, he'd come across a young lady who was probably in her 20s, and she was quite a talented pianist, and she had been playing a piece. And somehow during that part, she had moved her head and she just stopped and went into a catatonic state and didn't really recover from this. And so, of course, they were able to feed her, take care of her, but she really had no ability to take care of herself. And Dr. Still was taking her as a patient and saying, what could you do? And he was like, well, I don't know. I can just see if something isn't right. And when he went down and looked at her ribs and in the neck area, he found something that seemed to be pinching an area of a nerve. And he released that. And she immediately went to finish off the piano piece that she had been in the middle of, which was quite, again, fascinating to Dr. Still and stuff. But it did show us that at this time for mental health, you either would take care of that person as a family member in your own home, or you would put them in asylum and they were out of sight and out of mind, and that was going to be their life forever. Next. Which brings us then to our medical school and Dr. Still needing to understand abnormality. If you don't know what normal is, how do you know what is abnormal? And that is done, as you know, through the cadavers that are donated through various family members to the school. And we have our wonderful ceremony coming up, the gift of body, and appreciate that gift as your first patient. And but the challenge back in those days was getting cadavers, especially at a fledgling school like ours in Kirksville. And so our professor of anatomy at that time was William Smith, the man in the hat. And he came from Scotland, from Edinburgh, the Royal School of Surgery, one of the best schools in the world, and actually just happened this way because he heard of Dr. Still's miracles and wanted to see if they were true. And when he did, decided to stay, learn more about manual medicine. But as an anatomy teacher, he needed cadavers for over 600 students. We would have 203 different classes throughout the terms of the year. So a large number of students, but not very many bodies. So next. One of the places that you could get those would be the asylum. And you can see the size of this institute. This is in Cook County, Chicago. If any of you are familiar with the area, it's kind of a rough place today. It's called the Dunning Insane Asylum. The only reason it had the name Dunning is that was the nearest train station. So it was named for the train station. There were a lot of scandals because, again, everybody's medical schools are needing cadavers and bodies. And rather than bury the dead, they would often sell them and make a little side profit. So William Smith had heard about this opportunity, took a train, went to Chicago, gets to the asylum, and they're kind of going through the ward, and he's there to pick up 4 cadavers, 3 men and a female. And as they're going through the ward, the watchman says, and there's people that, today, at that time were considered what they consider freaks because of some genetic deformity. Maybe they had an extra digit, or maybe their face was covered in hair from some kind of, genetic issue or whatever. And as they're going through looking at what this ward of people would be, and in that case, they were calling them the freak ward, he said, "Do you see anything you'd want for your class?" And William Smith was taken aback. It's like, these are human beings. It's like, I've come to get the cadavers I was promised. It's like, oh, well, this is the killer ward. And, they often wander off and nobody will miss any of them. And Smith made it clear that he was only there for people who had passed and died, as best a natural death there. But it did shock him. And that later became a huge crisis because when he got the bodies, the woman who they got was a daughter of a prominent person, and they still wanted to bury her. And when she was dead and they couldn't get the body, it was a scandal across all of Chicago. They literally chased William Smith back to Missouri and wanted to extradite him and try him for a crime of actually taking sheets because a body isn't worth anything. And our governor, Lon Stevens, who used osteopathy, made it legal here in the state, said, "What is this problem?" It's like, well, we can't get any cadavers. And he says, well, here's the thing, that will no longer be a problem. We're not extraditing you. Chicago can, basically pound sand. And we're going to make sure that through Kansas City University, the osteopathic school there, they will divide the cadavers out, and everybody in Des Moines and here, and we'll get their fair share. So that's how we ended up getting cadavers and no longer needing to go through this somewhat nefarious process. Next. Which brings us then to, how did we get to a situation where the sanitariums were more kind and helpful? We've seen what the asylums kind of were like with many bodies, and all they did was just put people in. Nobody really ever came out of those institutions. That was the idea, and there were never enough of those kinds of institutions. So let's go back now to Dr. Still. He hadn't started the school. He probably hadn't even named the idea of osteopathic healthcare. But he's still working, he's doing some healing, he's doing some natural things, as was Arthur Hildreth's mother. She was kind of a home remedy woman, and she was fairly successful. And so she hit it up with Dr. Still. They shared a lot of ideas. They got along really well. Her husband had a swallowing disorder, dysphagia of some sorts, whether it was a cancer or neurological damage. It didn't matter. He often would suffer and couldn't swallow. And Dr. Still was able to work and do some manual medicine and get him some relief. And so Arthur Hildreth was familiar as a little boy seeing this guy come quite a bit to his family house. And one day they go on for a little walk down in the ravine and the creek, and he doesn't really think much of this old guy. But as they're picking up stones and stuff, Dr. Still starts identifying, hey, do you realize the strata and how these form and how this process works? And Arthur Hildreth was suddenly fascinated by the knowledge. It wasn't just the human body, but this person knew all sciences and had a familiarity with, the geology of the earth and stuff. And so it really prompted Hildreth on this path of learning. And he always admired Dr. Still as kind of kickstarting that within him, that curiosity about the world. Next. So Arthur Hildreth basically grows up. He's one of the first students. What his claim to fame for is in osteopathic healthcare is that a lot of states didn't want to pass the law to make DOs legal physicians. As a matter of fact, even Missouri, that was actually the governor before Lon Stevens, Stone. He was in the pockets with the MDs, even though the Senate and the House of Representatives voted on a bill to provide physicians to be legal. As the governor, he had to sign the bill. Stone didn't. And kind of is a good thing, because actually that bill said that you had to already be a doctor, and that would have destroyed us. So by him pocketing veto, by not passing that bill, which would have destroyed us, we had a second chance to rewrite it. And when Lon Stevens comes in, anybody could go through the medical school, and here we are today. So it really was fortuitous that we did not get the bill passed the first time. But what ends up happening is, after it's legalized in Missouri, Arthur Hildreth goes state to state to state, showing what manual medicine is, because they're all like, we hear it's a horrible thing. It's like, no, 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 let me show you. You do a little, muscle energy technique, or a little high velocity if there was need. But he would treat the people in the politics, and they were like fascinated by this and said, is this it? Yeah. Voted it state after state after state. And so he really made osteopathic healthcare legalized throughout all of the United States. And he comes back as the dean of students, kind of working in the school. Things are going really well in the United States and stuff. Next. And so we can see that they had this long relationship. Here's a young Arthur Hildreth, as we would look at him kind of as a fun guy, and a younger Dr. Still. And even when Dr. Still, towards the end of his life, these are probably his last year, and a much older Hildreth. But you can see that they maintained their friendship, throughout, decades of living together. And so it's kind of fascinating. Next. So as one of the first students, and one who really knows osteopathic healthcare well, and has seen Dr. Stills miraculously working with mental health, it's interesting, how even alignment in the nerves and how things can actually affect the body. Dr. Still works with his wife, who has a variety of health issues. And by about 1913, Kirksville used to host the National Osteopathic Association meeting, like we just had it in Nashville last week. And actually, Jonathan and I were together and hung out together a little bit in Nashville. But this annual event where everybody comes together, certainly if you're in the field, something you'll want to do sometime. And so they don't want to come to Kirksville because there's not enough hotels. Because when they come to Kirksville, all the locals would open up their homes. And it worked, kind of, but it really wasn't the best situation. So Hildreth and knows that Dr. Still, he's getting old. He really doesn't want the organization to be somewhere else. He would love for everybody to come home to Kirksville. And so Hildreth negotiates with his political, abilities, and they decide it's going to be in Kirksville. And his wife, Margaret, comes down with cancer. And so the plan is that they'll have this celebration in Kirksville in 1913. And it ends up that just before the event, literally days before the event, she passes from her cancer illness. And the Still family is like, as you had planned to come here and celebrate, bring your wife, because her family's all from here. She's gonna, basically be buried here, and she is. She's buried over in the cemetery next door with Arthur Hildreth. Go ahead and bring her, and we will bury her, and you'll be supported by all your friends of osteopathic healthcare. And so that's kind of the plan that is made, and it kind of works out okay for Hildreth, because he's really in a funk. He's horribly depressed. AT still recognizes this. His wife had died a few years earlier, Mary Elvira, and she was his rock and probably the reason he was successful. Because I understand where you're at and you're kind of in a funk, and we're going to get to that. We need to do some healing with you and your depression. Next slide. And so, like I said, the day after her burial, Charlie and them, they all have kind of an idea maybe to help Hildreth, because now that he's lost his wife, his daughter is getting married in a few months. He's going to be kind of alone, and he's done most of the things he wanted to do in life. And so what came was there an opportunity possibly to create a sanitarium in a neighboring area, and they need somebody to manage it. And Dr. Stowe's always wanted to do more with healthcare, but never had the facilities to do this. And now they might have this opportunity, but they're too busy. The school's growing, things are growing. They would want Arthur Hildreth to take on this task. And so he's thinking about it. Next slide. And so again, as we think back to the two terms, we have what is a sanatorium, which typically is treating a specific disease, maybe like tuberculosis, but also is more health focused, your diet, getting fresh air, fresh food, exercise, a variety of things that we would consider part of the osteopathic philosophy of body, mind, spirit, and a healthy lifestyle. Where we think of a sanitarium as something that would actually maybe work more as a spa, but also with the mentally ill. And that term kind of fell out of popularity. And again, now we think of a sanatorium as being more of what we think of as a healthcare facility. Next. So the opportunity that made this happen in our area was what was called the Blease Academy. Colonel Blease actually was from Europe, came to America, loved the military, and had produced a tiny little school to train future military war leaders. His father was in Prussia, had a wealth of money, hated what his son was doing, and for the most part pretty much wrote him off, but dies young, his father, by times. And literally millions upon millions of dollars now come to Colonel Blease in his little academy, and he decides to build his dream academy. This building, and it's still here in Macon, so if you're going south towards Columbia, you'll see it's at the very edge of that town. It had glassed ceilings, which was unheard of. This is 1899 when it was built. Glass ceilings so light would come through. They could march whether rain or snow. They had their own greenhouses, massive buildings to produce their own food, massive lakes, tunnels throughout the area to go to the city quietly, privately. They had their own dairy farm. They had everything they needed to be completely self-sustained as a military camp. But you can see how this would also work for a sanitarium where you wanted everything to also be contained and people could have their own space. And so he, like his father, dies within 6 years of building this, probably spent like $90 million on this place in the middle of nowhere. And so now he has a heart attack, he dies, he's gone. This is 1906, and nobody can afford it, nobody wants it. And after 7 years, the wife is like, I got to get something out of it. So literally, she's offering it for pennies on the dollar. They're going to get this place for nothing just so she can make a little money, because as it is, it's sitting still and nobody can afford it, nobody wants it, nobody's using it. Next slide. So when they go and see this, of course, Arthur Hildreth is still sons and AT. They're basically, this is exactly the opportunity we need. And so when we look at this, again, they were kind of anxious to look at managing this, who would run this big facility and stuff, but it would be the perfect opportunity for Arthur Hildreth to take command of this. Of course, it was new and they didn't even know what kinds of things to help the mental ill. They just knew it was out there and people were being just thrown away. Next slide. And so when it opened their doors, it was really the first opportunity of help that you actually might get better, that this isn't where you were going to die at this institution. And what Arthur Hildreth says, we tried all kinds of things. They were, again, trying to, some of the patients that came there were pretty normal people. For photography, it was a brand new thing. They were using basically a variety of chemicals like cyanide to make the photograph set. So you'd have a permanent picture taken, but they were using their bare hands in doing all these photographs and working. The cyanide as a heavy metal was leaching into their system, going into their brain, and they were going crazy. And so some of the experimentations done at this sanitarium was basically heavy milk, heavy cheese, heavy fat diets, which helped collect those heavy metals out of the brain and brought them back to normal. And so again, things that they're trying, socialization to help people, with their mental illness, work therapy in sports, a variety of things. And there was actually new chemicals, finally medicines coming out. And so we're seeing new things, as Jonathan had mentioned, at this institute that had never been tried. And what Hildreth is saying is if you stay 6 weeks, there's a good chance you would get healed. And they're doing manual medicine treatment, all kinds of things. And about half the patients are leaving. Sometimes people were just so stressed, they just needed a break. This gave them that opportunity to get back into sync and then go home. And so nothing was like this, which is good because these institutions that just kept growing and growing and growing, they couldn't sustain that. So by having a facility where people came and went and more people came, it was a better business model. And suddenly Macon was making quite a bit of money off of this institute. The job, it was all centered around the sanitarium. Next slide. And so again, as we mentioned from the very beginning, they didn't really have a clue, but they worked at it. They tried to figure it out, and they were very successful. Remember, this was 1914 when they opened the doors, and it stayed open until 1967. Why it closed at that time, a lot of things had changed in insurance and payments, even some of the new forms of medicine saying, hey, we don't need these other things because, we now have psychotropic drugs, and that's the answer to everything. But the sad thing is, after they then closed the sanitarium, what they realized was a lot of these things we did were very good, and we've had the files, we have the records, we've gone back and relearned from what was learned in those years as the institution. Next slide. And so you can see this institution as it was with its legs, again, full dairy farms. It had all kinds of greenhouses and really was an amazing, because of the money spent on it, who would have ever created a facility like this for people with mental illness? But it did pave the way that after this, it was the footprint for all of these sanitariums throughout the United States, just as AT still, as it grew into the institution, became the footprint for all 71 of the osteopathic universities that we have today. Next slide. And so Dr. Still actually had his first stroke that year in 1914. And so it really was a slow process of him getting ill and weak until he died in 1970, within 3 years. But he still took an interest in what was going on, though he couldn't be down there. If he was healthier, it's amazing what he might have been doing down there. But he was getting the word, giving some advice, and staying here in Kirksville most of the time. Next slide. And so we see Dr. Still as, again, a kindly person with really no stigma about, being any grade or titles or things like that. And he writes his last letter before he dies. He always would give a kind of a letter of support or things to think about to the students at the end of December for starting January, the new year. And the last letter he was writing to the students was actually talking about the work being done in Macon and how good it is. It'd already been open for 3 years, the success, and why this was some of the greatest thing that osteopathic healthcare had done is look at mental health and put people back to work back in their homes. Okay, there it is.
Thank you, Mr. Haxton. It's incredible to think of what was going on in 1914. And I don't know if you pointed this out, but I was looking at those pictures of Still and Hildreth, and those looked to me like perhaps history's first selfies as well. So I thought that was pretty neat looking at those two pictures. So where I'm going to take us now is talk a little bit about how osteopathic medicine has taken us on an interesting ride with mental health since 1914, 1917, 1967, and beyond. Certainly for many of us in the audience, myself included, when we wrote our personal statements about applying to osteopathic medical school, we might have written something about this mind, body, spirit idea, about the osteopathic tenets that are tested on COMLEX, the body's inherent capacity for self-healing, these relationships between structure and function. And I would posit that in the next 33 minutes, we might understand and increasingly appreciate that these aren't just historical principles, but they're actually a predictive framework for the mental health challenges that we face today. So my proposal is that actually a modern osteopathic approach integrates well with conventional psychiatry, with more of the medications and therapy model, but gives us a deeper understanding of physiology that we might apply to treat a whole person. So again, modern science really shows us, and if anything, it's reinforcing some of the things that we saw in the writings of Still, the writings of Sutherland. We'll talk about Fulford in this conversation. And in psychiatry, in my psychiatry residency, as I was working up case formulations for a patient that I would see in our acute inpatient psychiatric unit, a modern day version of the sanitarium, where our stays aren't for 6 weeks or 6 months, but we're asked to get people in and out in 10 days, we still have to look at what's called the biopsychosocial model, or sometimes a biopsychosocial spiritual model, where just treating a person with medications doesn't do much if you're going to discharge them back to a place where they won't have access to those medications, where they won't have access to taking care of their physical health, where they might not have people to help them navigate what it is to live in today's world with a mental illness. In osteopathy and osteopathic medicine, we also talk about these structure-function relationships. I'll talk more about that in a subsequent slide. And I thought it was timely as well that Mr. Haxton spoke about A.T. Still's first stroke, which, if nothing else, is really a reminder of what I think is still written some places on the wall in the building. There is that the rule of the artery is supreme, right? There is so much importance with circulation, with oxygenation, with glucose, with the ways these modern molecules that we understand as being responsible for proper mental and proper physical health. And in that mind, I'm also going to talk with you a little bit today with brief overviews of psychoneuroimmunology, as well as the gut-brain axis. Any one of these things could be a talk in itself, but today we're really kind of just testing the water and taking a look at some of these much bigger concepts. One thing that's been exploding, which is really kind of a no pun intended thing, is this gut-brain axis. And at the conference, at the AOA OMED conference that Mr. Haxton and I were at, there were a number of vendors that were focused on microbiome and talking about how much of attention in modern medicine is really looking to the gut. And of course, osteopathic medicine, this is something that we knew. One of the questions that I ask when I'm teaching our second year medical student psychiatry course is, okay, we're talking a lot about serotonin. We're talking a lot about norepinephrine and dopamine and acetylcholine and these different neurotransmitters. And I'll ask my class, where in the body do we suppose that most of those neurotransmitters are made and where are they stored? And many of the students will say, well, it's obviously the brain, right? That's the organ that psychiatry treats. But many of us may know, especially those who are osteopathically minded, that the majority of neurotransmitters are actually synthesized, stored, and utilized in the gut. And so this conversation between the gut and the brain is actually, it's constant, it's bidirectional, and it's something that's really critical for mental health. We've actually seen a number of treatments that are receiving various levels of indication of treating mood disorders through actually treating the microbiome and its metabolites. We're also looking at how inflammation and anxiety are often associated with these still somewhat fringe topics, but that are increasingly well supported in the evidence, whether it's gut dysbiosis or this idea of leaky gut, where the gap junctions in the intestines lead to inflammatory processes in the body, the systemic inflammation that then can cause depression and anxiety. So for me, it's very common when I'm working as a psychiatrist and treating patients clinically. Of course, if I don't ask my patient, I might not know. But often when I do ask my patients with depression or anxiety, they'll tell me that they also have bloating, they have constipation, they might have irritable bowel, or sometimes it might even develop into an inflammatory bowel disease, such as Crohn's or ulcerative colitis. And it works the other way too, where certainly our patients that we see with gut disorders often present with depression and anxiety. And I have to think that it's more than just these isolated symptoms. And I think that's something that early osteopathic physicians knew. And I think it's something that is coming back to us as we realize that our medications, while they're incredible, there's still a lot going on that we're not able to adequately address. Psychoneuroimmunology, or more appropriately, perhaps psychoneuroendocrinology, is an incredible topic, which there are several best-selling, New York Times best-selling books about this. And some of the examples that I'll bring to mind with this, or I guess starting with the mechanism, is we can appreciate, those of us who have had an exam recently, can appreciate that psychological stress can actually activate the hypothalamic pituitary adrenal axis, leading to cortisol release associated with things like weight gain, feeling inflammatory, having headaches, body aches. And if a person is exposed to enough of this chronic low-grade inflammation, it can contribute to everything from brain fog and fatigue to chronic pain and arguably all the way to fibromyalgia. Many of us may know that the treatment for fibromyalgia is certainly physical activity, but also antidepressants are commonly prescribed as a treatment for fibromyalgia. Our role as osteopathic physicians, my belief is that we really need to think about both upstream and downstream interventions associated with these things. Two specific examples that I'll give you for psychoneuroimmunology are patients with multiple sclerosis who have identified regions of plaques or hyperintensities on magnetic resonance imaging, or MRI. When giving antidepressants, we can actually see those areas of inflammation start to decrease. So our antidepressant medicines that we use, like fluoxetine or Prozac, sertraline or Zoloft, the list goes on, are themselves anti-inflammatory, which I think is really kind of an incredible thing to notice. In psychiatry, we also have a disorder that we call conversion disorder, which is somewhat of an outdated term. And what that describes is when somebody who, as a result of some psychiatric or psychological distress, develops neurologic symptoms, ranging from sensory changes to motor changes, all the way up to even cognitive changes as a result of the emotional burden that they're feeling. Now, this is a slide that is something that every osteopathic medical student should be very familiar with. We talk about the sympathetic and parasympathetic nervous systems, and in other disciplines, we know about those as sort of fixed things. The autonomic nervous system controls digestion, it controls our bladder function, it can control our saliva function, our pupils, it has a role in sexual function. The unique part that osteopathic medicine adds to this is that it allows us to directly manipulate and interact with the autonomic nervous system. So what does that mean? Let's take a patient who has anxiety, panic disorder, or trauma. Those things are often associated with muscle tension, rapid heart rate, and shallow breathing. To me, those sound like very easy osteopathic targets. Likewise, for patients with digestive issues, the parasympathetic system is a place that we can easily interact with. Whether we're working with the vagus nerve or the sacral plexus, those are all areas that osteopathic medicine, arguably over the last century, has really evolved to enable us to restore homeostasis, to be able to help the body and the system reach, if you will, a still point to balance the branches of the autonomic nervous system. So again, in osteopathic medicine, and this was something that they knew in 1914, it's something that we know now. It's a powerful tool for restoring this autonomic balance. We can use our hands to diagnose and treat things that we don't have a good mechanism for measuring. A person who has panic disorder is unlikely to have that diagnosed with a blood test or imaging. However, we can feel it in the tissues, we can treat it in the tissues, and often our goals correspond with down-regulating the sympathetic nervous system, improving the body's mechanics for those structure-function relationships, such as helping that person who's short of breath, helping their ribs and diaphragm expand in such a way so that they can breathe better and treat that anxiety, and of course, empowering the patient to enhance the patient's own capacity for their self-regulation and resilience. I had fun making this slide because I was actually able to capture some of the videos that I have on YouTube for some of these first two mechanisms. It's a much younger me there, but these are some specific techniques. And I'm not going to cover these techniques in detail. That's for another conversation, and one that I trust you're getting in your beautiful OPP lab. But if we think about suboccipital release, it feels great, but we're also directly influencing the vagus nerve, promoting parasympathetic tone and easing muscular tone, such as in tension headaches. Rib raising or thoracic diaphragm release, or a combination of those, directly activates or I should say deactivates and works on balancing the sympathetic chain ganglia and improving the mechanics of breathing. Again, huge implications in anxiety and in the way that a person feels. If a person is anxious, they don't breathe. If they don't breathe, it generates more cortisol, which further impacts their ability to handle the stress response appropriately. We have a direct intervention that can help right here. Now, I did not have a video for sacral rocking, so I had AI generate this image here, and this was what came up for sacral rocking, which I thought was not terribly far from the truth. But sacral rocking as well, it's a way where we can do a bottom-up approach to further encourage that rest and digest state to really help a person release the tension that's in their body. This morning, I was evaluating a person who's a former correctional officer who experienced incredibly traumatic things while they were in their correctional setting. And one of the scales that I use is a scale called the Hamilton, not Alexander Hamilton, different Hamilton, Hamilton Rating Scale for Anxiety. And as I'm going through that, nearly all of our anxiety scales that we use are associated with very physiologic symptoms. And these are things that, again, we can treat pharmacologically. We can teach a person through therapy to adjust to it, or you can interact with the person hands-on in front of you to help regulate these systems and to help show the person how to regulate these systems for themselves. So let me give you a case. And these are all real. I have two cases I'm sharing with you. These are common cases for me that are based on patients that I've seen recently and long ago. I'm going to introduce you to a 35-year-old man, and he's been diagnosed with panic disorder as well as gastroesophageal reflux disease, or GERD. This patient has a history of a poor SSRI response. You give this patient fluoxetine and they actually get worsening diarrhea. It's not a good situation for them. Because of that, they've been prescribed benzodiazepines like lorazepam and clonazepam, which is really a problem because now they're starting to feel sedated. It's harder for them to do their job and drive and get through those things. And in spite of the benzodiazepines being on board, this person has tightness in their chest and racing thoughts. On structural exam, I noticed that this patient had upper thoracic somatic dysfunction, as well as restricted diaphragm motion and a lot of suboccipital tension. Quite conveniently, this overlaps with the techniques that I was discussing earlier. So in terms of my integrated, I work with the patient. If I have a patient who wants to work with their medications, we do that. If I have a patient who wants to pursue anxiety that rely less on medication, we do that. In this particular patient's case, I noticed that there were opportunities to work with a medication that was a little bit better for indigestion. And in working with the medication, I also want to taper the benzodiazepine, because one of the things that I'm doing by introducing a medication that has strong parasympathetic tone and then in withdrawal creates a strong sympathetic tone, many benzodiazepines can actually make a person's experience of anxiety worse. So my goal as a psychiatrist is to help limit that cycle that's making this person's anxiety worse. Ended weekly psychotherapy, specifically cognitive behavioral therapy, borrowing from another school of thought to be able to help the patient learn skills and gain insight into his panic disorder and how that was impacting his digestion. And then we also recommend focusing again on thoracic areas to address that sympathetic chain, diaphragm to assist with breathing, and cranial to assess everything that's associated with the primary respiratory mechanism. Associated with that were reduced panic attack frequency and severity that we could measure, decreased chest tightness and reflux symptoms, and the patient after 6 weeks was successfully off of benzodiazepines, which was a really good thing for him, for his job, and his family obligations. I mentioned this a little bit earlier, where if we look at the DSM-5, and this is a book that I keep a copy in each of my offices, because the DSM, for those who have not had their psychiatry course or a psychology course in undergrad, is the book that we use for our criteria to diagnose mental disorders, so that we can have inter-rater reliability, whether I diagnose something or another psychiatrist does. And if we look specifically at the criteria for panic disorder, as you read through these, you'll see that so many of them are associated with physical sensations. Palpitations, pounding heart, accelerated heart rate, sweating, which should have its own line, but it's over here for some reason, As I'm reading through these, I'm thinking that sounds to me like a T through T2 to T4 dysfunction. Trembling or shaking, shortness of breath, chest pain, discomfort, nausea, feeling dizzy, unsteady, paresthesias, numbness and tingling, derealization. So many of these things are physiologic symptoms, but they describe a mental disorder. Mr. Haxton was insightful to remind me to include Dr. Fulford in this discussion as well. And Dr. Fulford often comes up in an osteopathic curriculum, specifically for his use of the percussion hammer and different things. What I think Fulford did really well was this idea of post-traumatic stress disorder and believing that trauma isn't just a memory, energetic imprint left in the body. It's a place where people get stuck physiologically, perhaps energetically, emotionally, and mentally. And the Fulford view of what we would now call PTSD is that, again, this shock of the traumatic event, the body becomes frozen. It lives in the fascia. It lives in the nervous system. For those who are doing dissections, you can appreciate the strength of that fascia and how it really ties us together. Fulford knew that. As osteopathic physicians, we know that. But I can promise you in my psychiatric training specifically, we never talked about the fascia. I think it's a place we should pay attention. Fulford talked about how there was a lesion pattern that would force the autonomic nervous system into a state of perpetual threat, always ready to fight or flight. And if we zoom out and look at diagnostic criteria for post-traumatic stress disorder, it's no surprise that hypervigilance, the always looking around, and the body symptoms of PTSD very much overlap with an osteopathic understanding. And so the goal of for Dr. Fulford and for those of us who carry these things forward is gentle treatment, allowing the body to give us permission to help it find that still point, releasing that traumatic memory, and freeing that inherent self-healing mechanism. It's not uncommon for people when they are having us release as well. Every osteopathic physician who uses hands-on techniques can tell you at some point started sobbing. They feel a release from something. You might be working on the head and the legs, right? There are these incredible connections across the body through fascial patterns, through energetic patterns, arguably overlapping with Eastern views of medicine as well, whether we're looking at chakra-based understandings or meridian-based understandings in Chinese medicine that overlap with what we learn as osteopaths and osteopathic physicians to better understand these things. In this bottom right corner, I have a book that's very popular in non-osteopathic audiences as well as DOs. It's actually written by an M. The Score. And this is an incredible book about how the brain, mind, and body both hold on to trauma as well as can be treatment targets for trauma. So let me tell you about another case, and this is a case that I saw actually as a resident physician shortly after my graduation from KCOM. And this involved a 45-year-old veteran with post-traumatic stress disorder who reported some of these things that we're speaking of, the hypervigilance, the insomnia, chronic unexplainable rib seemed locked in and could not be explained through the x-rays, through the MRIs, through this very expensive workup that this veteran had received. Now, Dr. Fulford and us as learners of osteopathic medicine would say that the physical impact and emotional shock of the event are held in that fascia of the thorax. The diaphragm's restricted and it locks the body into this fight or flight breathing pattern as if the trauma is still happening. It's as if this veteran had never left what had happened much earlier in life. So an integrated plan for this patient included psychotherapy, and specifically focusing on trauma-focused therapy, such as somatic, there's that osteopathic word, right? Somatic experiencing, where the person is challenged to live in their body, to explore that tightness, to explore the traumas, see where the trauma is living rent-free, and figure out how to coax it out, if not evict it. We looked at medication, helping him with his sleep. We used a medication called prazosin, which works on the alpha-adrenergic system. Again, looking at physiologic approaches to psychiatric complaints, and avoided benzodiazepines, which can impair learning. We saw them being a problem in the first case. We see them again as a risk in this case. And this patient, this veteran, actually did very well with cranial osteopathy to calm the central nervous system, as well as balanced ligamentous tension techniques, helping to unwind the thorax and release that retained traumatic pattern. This patient told me that it was the first time that he could remember breathing in 25 years after we started our treatments. And again, in osteopathic medicine, you learn the tools so that each of us can have these incredible experiences to give patients something that they would not get other places. The outcome with this patient was, of course, gradual reduction in his hypervigilance. I mentioned about his breathing, and his rib pain seemed to resolve. Once in a while, it did still come back, but it was easy to make it go away, and it would stay away longer and longer with each successive treatment. So a modern DOS toolkit is really incredible. And I like to think of it as, in some ways, being an osteopathic physician, using the tools that we have, it's a little bit like we have superpowers. We have the ability to diagnose and treat things that can't be diagnosed or treated with lab tests or imaging very well. But we also have the ability to access psychopharmacology, which plays a role. I teach a course on it every year, and I look forward to it. We learn psychotherapy, and we learn versions of it as a medical student or resident. And then we also have the ability for lifestyle medicine, noticing that diet and exercise and behavior plays a tremendous role in a person's wellness and their ability to succeed. So again, I want to emphasize that lifestyle medicine, what we commonly call lifestyle medicine now, or preventive medicine, even in residencies, is really focusing on the same foundational pillars of health that A.T. Still knew, that Dr. Hildreth knew, that those staffing the Still Hildreth Sanitarium knew, that Dr. Fulford knew, and arguably that every KCOM graduate, and I see we have a couple DMU folks on and a couple CHSU folks, we want all of our graduates to know these things. We want them to know about anti-inflammatory nutrition, noticing that there are ways to use nutrition to improve how a person feels. Going through Kirksville, I can tell you I feel, differently if I eat at, Pagliai's or Pancake City versus somewhere else in town, perhaps. Emphasizing whole, fresh foods, omega-3s, and probiotics, these things that the gut-brain axis needs. Movement as medicine is something that osteopaths throughout history have known very well. Our modern version is writing exercise prescriptions. When I had a paper prescription pad in the office, we'd have less of those now, I would write out specific types of exercise with quantity, duration, frequency for patients to manage their anxiety, their depression, and there's a whole movement in mental health called behavioral activation that specifically measures a control group that might be on antidepressant medicine with a group that's prescribed just to go for a walk 20 minutes 3 times a week. Those groups are checked in in 4 to 6 weeks. And every time for every antidepressant that's tested, the group that's told to walk for 20 minutes 3 times a week has better outcomes for their depression and anxiety than the group on the antidepressants. I'm not slamming antidepressants. I prescribe them almost every day, but there's more that we can do if we want to take care of our patients. Sleep hygiene is incredibly important. I saw sleep being mentioned as one of the things that was going on in Macon, Missouri, or Missouri, if you're local, as a primary driver of psychiatric symptoms. Mindfulness and breath work also play a role, and I think that these practices are incredibly osteopathic, even if they are a little bit mainstream. I like to think as osteopathic physicians, at least as far as Western medicine concepts go, I like to say that we found them first. And I think this concludes our discussion today, allowing some time for question and answer if appropriate. I do genuinely, on behalf of Mr. Haxton and me, as well as the team that set this up, we do want to thank everyone who joined for your time on a second Monday evening, or Tuesday if you prefer, to join us for this discussion.
Great. Thank you so much. We are available for questions. If you're virtual, please put them in the chat or in person. You remind me, Dr. Terry, of my first interaction with the osteopathic psychiatrist who you may have known, Gerald Osborne, Dr. Osborne. Okay. So when I first came to Kirksville as the treatment coordinator at the residential treatment center, and somehow I got him to come see the kids there. I don't remember how I did that, but he would come see them there, and he would take out he still had the prescription pad then, and he would write down with the kids, like their vitamins, omega-3s, exercise, journaling. He would write it and hand it to them. Now, getting the teenagers to take omega-3s was a whole different story because he had to do the fish oil and the flax oil. And there was not the chewable gummy ones then, I don't think so. All right. Does anybody have any questions? Right. You can't see probably Dr. Terry up front because we have a lot of people sitting in the back, but we have more people here than it looks like in your video, probably.
Well, I hope it was worth everybody's time, and that you'll think about these things when you have your next Ronza at Pagliai's.
Yeah, for sure. All in moderation.
I just gotta say from graduation to residency, I know, 4, 5, 6 years ago, maybe there'd be one psychiatrist, in our group. And in the last couple of years, there's been up to 12 that are going residencies out of KCOM, because you see them at the banquet where they're going. So it's amazing how psychiatry has grown.
Thanks again. I had to point out we have Dr. Wilson here and Dr. Trish came to see you and Dan Martin. So,
Oh my goodness. If I knew Dan was here, I would have behaved myself.
okay. All right. Thank you so much. I don't see any questions in the chat. So thank you, everybody. Have a good night.
Thank you, friends. Have a great night.